Tonight we have Dr. Dean Ruether discussing new developments in treatment of prostate cancer. We did get that correct. That's the general
part of the talk.
that and some. So Dr. Dean Ruether's out of the Tom Baker Cancer Center, as many of you know. His specialty is medical oncology, GU, breast, and endocrine malignancies. Dean, I'll give it to you.
Thank you very much for asking me to come and talk to you tonight. I think it's been 2 years since I last had an opportunity to speak to you as a group here in Calgary. And when I was approached about doing this talk, my thought was to talk a little bit about some of the new treatments in prostate cancer, but a little more generally, what's new in prostate cancer care in Alberta as well. So, first question is there anything new? Progress in the management of treating any type of cancer is often slow, much slower than we would like. And so in preparing things for tonight, I thought, let's look back and see where we were a couple of years ago when I gave a similar talk to this audience. So a look back to 2009 when I did a similar talk. And back then, I talked to the group a little bit about where screening was for prostate cancer. Talked about some things that we were doing here in Calgary and in southern Alberta to try and improve patient care for patients affected by prostate cancer. I did a bit of an introduction around some new facilities that were being built that will have an impact on the treatment of prostate cancer and other genitourinary malignancies, and then talked a bit about some of these other issues, awareness and education, and what was happening locally with research and advocacy and fundraising. So let's look at where we've come over the last couple of years. Let's talk a bit about screening first. So in 2009, PSA testing was not routinely covered by Alberta Health Services. There's a lot of controversy even today. Pardon me. Prostate cancer screening was still felt to be controversial in that it wasn't clear that early detection of this disease actually resulted in lives being saved. No question on an individual basis that we identify the cancer earlier by in individual patients by looking for it, but when you look at large population-based studies, it wasn't clear that those early interventions were resulting in improvement in terms of outcomes for when you look at population-based screening. And so it is a controversial issue. It remains a controversial issue, but, and that largely comes from the fact that there are conflicting results from some of the large screening trials that have been done in the US and in Europe. But just in this last year, there have been published the results of a large trial that was done in Sweden. It's called the Göteborg trial. And this was published in July of 2010 in The Lancet. So this was a large study. 20,000 men in Sweden were randomized between a group who were screened for prostate cancer and a group who were not screened, just undertook testing if they developed symptoms that were suggestive of a problem related to their prostate. And the results of the study confirmed a lot of the challenges that we deal with in prostate cancer screening, the biggest ones being that we overdiagnose the disease. We recognize the disease in a large number of men, but we don't do very well in figuring out which patients are going to get into trouble if we don't treat this disease, and which patients could potentially, this could be left alone, is not likely to be a threat to their life over the period of time that they live with it. And that's still a challenge. And so we recognize that we overtreat this disease. If we diagnose it, we often end up treating it, but it's still there's still a lot of debate as to whether that treatment and the risks and the side effects that come with treatment, is that price worth paying in the sense of, are we saving lives with this intervention? But what this study showed is that it reduced the risk, the screening reduced the risk of dying from prostate cancer in a large population of men from 0.9% to 0.5%, and that was a statistically significant difference in those two treatment arms. Now, unfortunately, that's going to get cut off at the bottom of the screen. So what we learned from this trial is that in order to prevent one death from prostate cancer, we had to screen 293 men. In order to prevent one death from prostate cancer, we had to treat 12 patients. So that means 11 patients get the treatment without necessarily getting the benefit from the treatment in terms of it having an impact on their survival. But when you look at these numbers, they're very similar to what we see for breast cancer screening. So the numbers in terms of what is the number needed to screen and the number needed to treat to save a life from breast cancer are similar to these. And so I think there is a growing body of evidence to support prostate cancer screening, a mass population program. And the numbers that we see in terms of the benefits are similar to what we see for screening programs in breast cancer.
Dean, could I ask a question?
Sure.
What does screening constitute? What's that mean?
That in this trial, it meant a digital rectal exam and a PSA test. And that was repeated annually.
And PSA.
Yeah. So the circumstances are a bit different now, and this again is comparing back to where we were in 2009. PSA testing is covered under specific circumstances in Alberta now. I'm optimistic. We've been engaged in discussions with government about full coverage of PSA testing for the province, and I'm being told that that is an issue that will be addressed by the spring of 2011. So we keep the pressure on, and I'll let you know the next time I come and talk to you. But hopefully we're going to have full coverage for PSA testing sometime over the next year, and so patients will not be out of pocket for this test as they have been. And so this is raising the question, and this is something that the GU tumor group in Alberta is in discussions about right now. Are we ready for a mass screening program in Alberta for prostate cancer? That's a bit more of a contentious issue. It doesn't affect the potential for a patient to engage in what we would call individual screening, so a discussion with their doctor about the pros and cons of PSA testing and undergoing a digital rectal exam to screen for prostate cancer. That's a different set of circumstances than looking at what we would call a mass screening program, where you would offer PSA testing the way we offer mammography or colonoscopies for colorectal cancer screening. So we're in discussions about this issue right now, and it may well lead to the development of a mass screening program in Alberta. When I was here in 2009, or actually when we got together up at the Foothills Hospital in 2009 for this talk, I talked to you about new facilities that were being developed in Calgary and in southern Alberta. So the urology center was under construction on the top of the new parkade at the Rocky View Hospital, and that was the planned occupancy was for March of 2010. And the then Alberta Cancer Board, now Alberta Health Services Cancer Care, was developing what we call the radiation therapy corridor. So presently in the province of Alberta, if you need, radiation treatments for any type of cancer, that was only available in Calgary and Edmonton. But there were plans at that time to develop radiation treatment facilities in Lethbridge and subsequently in Red Deer and Grand Prairie. And so I'm pleased to tell you that as of 2010, The Southern Alberta Institute of Urology, those new facilities on the top of the parkade at the Rocky View Hospital are open, so they've been operating for almost a year now. This creates huge advantages for our program and also for patients. All of the urologists who work in Calgary are housed in that building, so they all have their offices in there. There's space there for education programs, teaching programs, other resources for patients, and creating an environment that concentrates the expertise is advantageous for our programs of care because of the it allows for good discussion between urologists, radiation and medical oncologists about research programs and other programs that we can introduce to improve patient care. So this has been a huge step forward in terms of us developing our program here in Calgary. And we continue to work with the urologists based there around opportunities to create multidisciplinary clinics for patients with prostate cancer and other types of genitourinary cancers. And also, the Lethbridge Cancer Facilities are now up and running. It's called the Jack 80 Cancer Center, and as of July 2010, those radiation treatment facilities have been operational. There are 2 radiation oncologists that have been recruited and are working there, and they have the capacity to deliver external beam radiation treatment for the common cancers: breast, colon, rectal cancer, prostate cancer, lung cancer. And this is obviously an advantage for Albertans. It means patients living in the southern part of the province can be treated closer to home. It has also helped us in Calgary because it's taken the pressure off of our facilities. Being the referral center for the whole southern part of the province, as you can imagine, created a huge workload, and we were struggling with capacity issues that limited our ability to see patients in a timely and effective manner. And the fact that patients in the southern part of the province can now be treated in Lethbridge, closer to home, in their own environment, and that's taken some pressure off of us, has helped us to meet our wait time expectations. And then, sorry, again, this is going to get cut off on the bottom. The Red Deer Cancer Facilities, the sod turning was in the spring, I believe, of this last year, and it's under construction, and those facilities will open in the first quarter of 2013. So again, there will be full radiation treatment facilities available there that will help to meet the needs of patients in Alberta. There are still discussions about opening a radiation treatment facility in Grand Prairie. That's probably farther down the road, maybe 2015, 2016. There's a need there for new hospital facilities, and so there's a lot of discussion going on right now about if we're building a new hospital, where's the appropriate place to situate a new cancer facility there, and that's one of the things that's slowed down those discussions, but I'm still optimistic that over the next 4 to 5 years we will have the capacity to offer radiation treatment to patients in the northern part of the province. And because we are the referral center for patients who come from the Northwest Territories, obviously it would be create an advantage for patients living in that part of the country. Having these other facilities open will also impact our ability to improve the care we provide patients. Some of you, maybe not all of you, but some of you may be aware of what we call our Rapid Access Program. That's the program that facilitates the rapid referral and biopsy and diagnosis of prostate cancer. We have an education program attached to that that's been running now for about 3 years, just over 3 years. That session is held every 2 weeks at the Southern Alberta Institute of Urology. And that's a program that is set up for patients and their families who are dealing with a new diagnosis of prostate cancer and who are trying to wade their way through all of that information around the options of surgery, external beam radiation therapy, brachytherapy, cryotherapy. There's lots of choices, and that's an advantage for patients with prostate cancer, but it also creates a situation that is very stressful, because how do I know which one is the right option for me, and why is my doctor directing me to look at options 1 and 2 and saying options 3, 4, and 5 are not on the table? So this education program is designed to give patients some background information about the various options, so that when they sit down with their doctors to talk about these treatment options, they can engage in that discussion in a way that is hopefully more meaningful and helpful. And with the availability of the treatment programs in Lethbridge, and the recent installation of the right type of video equipment at the facilities at the Southern Alberta Institute, we can now look at video linking our education sessions to patients in Lethbridge so that they can benefit from those as our patients do in Calgary. So we're just working through the hoops right now in terms of getting that education program linked to the southern part of the province, and our plan is to link that to Red Deer once those facilities are up and running as well. So I hope that shows you that within Alberta we have seen some exciting developments and improvements and expanded capacity to deal with this very common problem, and a problem that we recognize is going to become even more common as the baby boomers are entering the age where this disease is going to become a significant issue for them. We recognize that we're going to see a wave of patients over the next 20 years who are dealing with many types of cancer, prostate cancer being one of the most common ones, and we are struggling a bit with how we're going to deal with those capacity issues. Having these facilities open will help us significantly with that. So I'm going to change tack now and talk a little bit about what's new in the treatment of prostate cancer. And I think there are a lot of things to be very excited about in terms of an expanding number of options that are going to be available for patients. So we're going to talk a little bit about the treatment of localized prostate cancer and what's new there, but also for patients with advanced prostate cancer. Some very exciting developments there that we've been fortunate to be part of here in Calgary. So for localized prostate cancer, if anybody dealing with prostate cancer would probably have to be living under a rock not to be aware of the Vinci Robot. It gets a lot of press. It's a technology that facilitates the urologist's ability to perform this surgical procedure, prostatectomy. That technology has been available and used in Edmonton for about 3 years now. We finally got our first Vinci Robot just over a year ago. And so three of the 14 urologists in the city of Calgary have done the training to be able to offer robotic prostatectomies. I don't think there's any doubt that this is a significant step forward in many ways. Certainly it does appear to shorten patients' time in hospital. The average stay in hospital for a standard, what we call open prostatectomy, is usually 3 days. With the Vinci Robot, that stay is down to 2 days. So patients are out of hospital on average 1 day faster. There may be some advantages as well in terms of the potential risks and complications that go along with prostate cancer surgery by having access to the robot. It does create some challenges. It's an expensive technology to maintain, and the machine does need to be serviced on a regular basis, and those maintenance costs are hundreds of thousands of dollars a year. It makes this procedure itself a more expensive procedure to perform because there are a lot more disposables that go along with the procedure, so pieces of equipment that can only be used once and then have to be discarded. And it takes longer to do the surgery this way, and so that is creating a bit of a challenge in terms of our wait times. So as an example, a urologist could do 3 open prostatectomies in a day using the old procedure. With the robotic procedure, because it adds time to the procedure, he can only do 2 a day. And so that's going to create some challenges around wait times for surgery, and we're trying to figure out how to deal with those. We actually have the capacity in Calgary in terms of the number of ORs that we would need to expand the surgical capacity. We don't have the staff for the ORs, so several of our ORs are sitting unused right now because we don't have the nursing and skilled support staff to operate those ORs. So those challenges are going to need to be dealt with.
What's the basic difference between the robotic and the regular?
So an open prostatectomy involves a surgical incision, runs from the belly button down to the pubic bone, so about 6 inches or so. And the surgeon goes in through that opening and removes the prostate. With the robotic procedure, they make 4 or 5 small openings that they can put a camera in through and some equipment. The robot's hands have the capacity to move in a way that a surgeon's hands can't. So you've got 360 degrees of rotation in the robot's wrist that a surgeon doesn't obviously have. And the magnification that the robot allows you to have allows better visualization of what's going on with the procedure. And you can appreciate that working down in the pelvis, that's a very tight space for the surgeon to be working in. He's working around a number of other very important structures like the bladder and the rectum and the blood vessels and nerves that are important for erectile function. So better visualization is an advantage. And as I said, the capacity for the robot's hands to move in ways that the surgeon's hands don't move is going to create some advantages too. You still have to have a good surgeon operating the robot. It's not the robot doing the operation. So people sometimes have this idea that we just kind of click the machine on and it does the work. But it's still operated by a surgeon. But it's a pretty amazing piece of technology. And I think the other thing that's exciting about it is that it has application in prostatic surgery, but also in other surgeries, particularly operations for bladder cancer, operations for kidney cancer. So I think this technology is going to have an impact in other areas of genitourinary cancers as well as the prostate.
Thank you.
I think there was another hand at the back.
The only real difference is you're just eliminating a large incision.
Well, you're eliminating a large incision. There's less bleeding, a shorter hospital stay, and where the surgeon has to stitch the bladder back to the urethra that drains urine from the body, because they have to transect that when they remove the prostate, that anastomosis is better with the robot. You get a tighter anastomosis and less risk of leaking with the robotic surgery. Again, probably because they're able to visualize things better and see what it is they're stitching together.
Do they have a better look at the lymph nodes?
The robotic surgery makes lymph node dissection more challenging. So patients are directed to the robot, or the option for the robotic surgery is there if you are dealing with a set of circumstances where we don't think there's a need to look at the lymph nodes. If you're looking at surgery for prostate cancer and the surgeon feels that this is a situation where it's very important that I examine the nodes and remove some of those for examination by a pathologist, then that probably is better done by an open prostatectomy.
So, Dean, what's the track record of this technology when you've decided that you don't need to look at the lymph node?
Mm-hmm.
And we're comparing basically the manual technique versus the Da Vinci. What's the history in terms of progression and survival and things like that?
Yeah, so good question. And important to remember that this is still relatively new technology. So we don't have 20, 25, 30 years of follow-up in patients who have been studied in a randomized controlled fashion. So a group of 100 patients who had the open procedure versus 100 patients who had the robotic procedure, and then you follow them for decades. And in any intervention related to prostate cancer treatment, in order to determine whether there's an advantage, you really do have to follow patients up for 10, 15, 20 years to see the outcome differences. To date, there is no difference in terms of cancer control rates. So the robot doesn't seem to be better in that sense than the open procedure. But it does appear, as I said, to shorten hospital stays. It's associated with less risk of bleeding, and it may create some advantages in terms of the anastomosis that the surgeon has to create. If you go on the websites, particularly in the U.S., where medicine is big business in the U.S., particularly surgery, So you can find any number of websites that'll be advertising, you come and we'll do your Da Vinci robotic prostatectomy for you. And one of the things that they claim is that issues related to potency and preservation of erectile function are better with the robot. I don't think we know that yet. I think it's possible. Certainly, as I said, the visualization is better. But in fact, when you talk to surgeons who do this procedure, when they're doing what's called a nerve-sparing prostatectomy, so trying to remove the prostate and protect those very delicate nerves and vessels that sit right on the outside of the gland and that are important for sexual function, they can't see those most of the time anyway. They're so fine that even with the magnification the robot provides, you can't visualize those in most circumstances. So they know where they are, and it's a little bit like if you had an onion and you peel that dark, coarse skin off the outside. Underneath that is that really fine sort of membrane. That's a little bit like what they're dealing with. That's where those nerves and blood vessels sit. So they have to peel this very delicate layer of tissue away carefully. And I think it's still questionable whether the robot is going to make a big difference there. It has the potential to, but I don't think we know. We haven't long enough follow-up yet. But certainly, cancer control rates are equally effective. Patients are out of hospital a little faster, and there's less risk of bleeding. So there are advantages to this procedure. And I think it's extremely unlikely that we would see a negative impact on some of these other issues. So it's not going to be worse, and in some ways it may be better.
Why couldn't they work, if the robot does two a day and the surgeon does 3, why can't they work late in the evenings?
You'd have to ask the surgeons.
What is the problem in not being able to use the OR rooms? Is it
We don't have the nursing staff.
But are they available if you had the funds to hire them?
We laid off a bunch of nurses a couple of years ago, remember? Don't get me started. Yeah, the problem is that we don't have the nursing staff that we need. So
But is there funding to pay them if you did have them?
that depends on who you ask. Yeah. It's frustrating because there are in the new McKeag Tower that's been built adjacent to the foothills there are a number of brand new ORs sitting there that have been unused for months because we don't have the capacity to open them. So you can't. It's great to build new facilities, but if you don't create the infrastructure to operate them, they're not terribly helpful. And that's the challenge we've been dealing with over the last couple of years. Are there any other questions about what you've heard so far?
Well, about 3 or 4 years ago, when we were having the meeting in the foothills, there was a talk about that this treatment, as you were mentioning, to protect the nerves from being cut while in the operation. And at that time, they were mentioning that the speaker who said he did it had to pay $3,000 for the operation to preserve the nerves. And they had to come from his own pocket. And he was saying that later maybe it will be covered. But that was his alternative. Either have the operation and lose his nerves and the association of potency, or pay the $3,000 and keep his nerves.
So at that time, 3 or 4 years ago, we didn't have the robot. I think what you're speaking of is the robotic surgery. That was not available in Alberta. So if a patient wanted to pursue a robotic procedure, they had to go elsewhere. And most patients went south of the border.
No, it was here in Canada. But they had to pay for it. It was not covered.
Yeah.
And that is what the speaker said at that time.
Yeah.
He had the choice of paying the $3,000 or lose his nerve.
I think it's really important, though, to what I just spoke to about the fact that the robotic surgery is not a guarantee that potency will be preserved. So it's not a matter of saying if you have an open prostatectomy, you will have problems with potency, and if you have a robotic procedure, you won't. Any treatment for prostate cancer, whether you're talking surgery, whether it's done by robotic or otherwise, external beam radiation therapy, brachytherapy, cryotherapy, all localized treatments for prostate cancer carry with them a risk of having an effect on potency and bladder control. And that's simply because of the anatomy. Those other structures sit right in around the prostate cancer, and they get in the way of us trying to treat this problem. So it is hoped that things like the robot will improve our ability to preserve erectile function and have an effect on the risk of incontinence. And that may be the case, but I think the jury's still out. So, okay.
How successful was the man van? Is it still going?
Oh yeah, it's been a very successful venture. Yeah, yeah, and it is still operating. Will be. I think until such time as we have, PSA testing appropriately covered, and even after that, it does community outreach. So gets to patients who maybe wouldn't necessarily go and see their doctor regularly. Surprise, surprise, men are notoriously bad for seeing their doctors about their health. And so I think we will always be looking for opportunities to reach out to patients and make these kinds of things available for them, whether it's paid for by Alberta Health Services or not. So I think there's always going to be a role for those kinds of novel and innovative outreach programs like the ManVan.
What is the ManVan?
It's a van. It was purchased by the Prostate Cancer Center a few years ago, and what it does is it provides for mobile PSA testing. So the van goes out to various events, and men can go to the van, sit in the van, have their blood test drawn. They can have a PSA test done right then and there and get the results, and then be counseled as to whether they need to go and see their doctor or not. And it's been operating for, how long have we had the ManVan running? 3 years? Yeah. So it's been very successful.
In Alberta?
Mm-hmm. Yeah. Mostly in southern Alberta. Mostly in Calgary and in southern Alberta. There's talk about purchasing a similar and organizing a similar program in the northern part of the province, in Edmonton. I don't know where those discussions are at right now.
I was just going to add that we have started putting the ManVan schedule in the digital examiner, so if there's somebody you want to suggest to go and have their PSA done, it is the PSA done for the first time. It's the first PSA test. You can't go back to the down and George check.
Yeah, it's a one-time only.
Yeah, but we do have it. It's going to be every month in the digital examiner, so if you want to know where it's going to be, just open up your newsletter and be there.
I hope it's not a silly question, but is there any other test for prostate cancer besides the PSA test?
Not yet. The best tests we have for screening for prostate cancer are the PSA test in combination with a digital rectal exam. The two alone are not as effective, the two individually are not as effective as the two done together. So it is important for men to understand that the PSA test is only part of the screening. The digital rectal exam is also an important part. And there is no better test yet. There are some other technologies looking at testing, looking for certain chemicals in the urine that may be more effective down the road, but they're not available and not ready for prime time use just yet.
Yeah, I have a doctor that doesn't believe in it, and because of some thing that happened in England that screwed the whole thing.
It's still very, yeah, it's still a contentious issue because it's not as specific a test as we would like. So the PSA can be elevated for reasons other than prostate cancer. Benign disease of the prostate, infections of the prostate can cause an elevation in the PSA. So it's not as specific a test as we would like to see, and it doesn't detect all cancers. A man can have prostate cancer and not have an elevated PSA. So it's not the final answer, but it's the best thing we have right now.
So if a PSA is very elevated and no biopsy was done, but treatment is chosen.
Well, we would Depends on how high the PSA is. If the PSA is 100, it'd be pretty hard for that to be due to anything other than prostate cancer. Even if the PSA is 30, 40, 50, that's almost certainly going to be prostate cancer. If the PSA is around 20 or between 10 and 20, that could be prostate cancer. It could be other things. So that's why I said, the digital rectal exam is an important part of the assessment, and it really needs, those results really need to be interpreted with a physician to decide what's the next step. Do you need a prostate biopsy? Because ultimately, that's the way you make a diagnosis of prostate cancer, is by a biopsy.
So the digital is negative. The PSA is very elevated.
Depending on how high very elevated is, that patient probably needs a biopsy. 117, that's almost certainly prostate cancer.
But no biopsy.
Yeah, if other tests are done to determine whether there's cancer in other parts of the body, then you may not need to pursue a biopsy.
Can the biopsy itself cause a spike in the PSA?
Yeah, it does. Any manipulation of the prostate gland will cause an elevation in PSA. So we would not recommend to a patient who has had a biopsy done that they repeat a PSA within a certain period of time after that, because it's a meaningless test. It will be elevated.
Is there any tests for women? Tests for women for breast cancer and stuff?
Mammography, yeah. Yeah, and it's a very effective screening test. It does detect cancers earlier, and mammography has definitely saved lives because it detects breast cancer earlier, pardon me.
Also pap smears.
Pardon me?
Pap smears?
Pap smears for cervical cancer, that's another example of where a screening program has been very effective in reducing the risk of dying from cervical cancer. Yeah. Yeah, screening is effective for cervical cancer, breast cancer, colon cancer. Those are the three areas where we have good evidence to show that screening programs make a difference and save lives. There may be ways of screening for lung cancer that could have an impact there. To date, we haven't developed a screening test for lung cancer that results in early enough diagnosis that it results in lives being saved. Prostate cancer, there's a lot of debate about that still, but I think a growing body of evidence that shows that screening probably is effective in saving lives. And then there are other types of cancer where we still don't have even an inkling of a screening tool that would be helpful. So.
Is it true that a biopsy could cause the spread of the prostate cancer?
No, that's a very common concern we hear from patients, not just about prostate cancer. Putting a needle into it will cause it to spread. Having an operation and opening it up to the air will allow it to spread. That's never been shown to be the case except in some very, very unusual types of cancer, some sarcomas, cancers of muscle, and cancers of the adrenal gland, where probably isn't a good idea to be sticking needles in them because you can cause spread of disease along the needle tract, but not been established to be the case for common cancers like prostate cancer, breast cancer, colon cancer, lung cancer. And the information you get from the biopsy is extremely important in determining what kind of cancer we're dealing with and what the treatments are, options are for patients. So you can't downplay the importance of the information we get from a biopsy. So I think there was another.
Now, when you were here in October of 2009 with Cheryl Scott,
yeah,
both of you spoke regarding a target of 2 weeks, 2 weeks, 2 weeks.
Right.
How are you meeting that target? Have you got?
We're doing pretty well, actually. We track the data from our rapid access program, and the intention was from a time that a man has been recognized to have a problem by his family doctor, either an abnormal rectal exam or elevated PSA or both, to when they see the urologist for a consultation to decide whether a biopsy is necessary. We wanted to have that down to 2 weeks. The time from that assessment by the urologist to a biopsy down to 2 weeks, and the time from biopsy to the patient sitting down with the urologist to talk about the results of the biopsy to 2 weeks. And we can show that over the last 2.5, 3 years, we've been able to meet those targets for more than 85% of patients who are referred and go through that process. So you'll never be 100% because their appointments get canceled or missed, or patients decide they don't want to come in 2 weeks. They'd like to be 3 weeks works better for them. But we're meeting that target at more than 85% of the time. So we're quite pleased and quite happy with the success of that program. And then the education program that we offer runs every 2 weeks. So theoretically, a patient shouldn't have to wait any longer than a couple of weeks to get into that session from the time that they sit down with their urologist to hear about their biopsy. And then from there, if you are referred on to the cancer clinic for a consultation, we track our wait times for those, and we try to keep those referrals down to 3 weeks. And again, with Cheryl's help over the last couple of years, we've been able to keep maintain those targets for between 80 and 85% of patients who are referred to the cancer clinic. So we're doing pretty well that way, I think.
Dr. Ruether, the Alberta Healthcare website has a very detailed treatment protocol there for prostate cancer, as well as many other cancers. My question to you is, how closely do Alberta Healthcare oncologists have to follow that protocol, and whether they have any freedom of action to deviate when their personal judgment dictates that it might be appropriate?
Yeah, so what you're looking at there are guidelines. They're not prescriptive, and it would be, I think, dangerous to try to use them that way, because you can't, nothing can replace a physician sitting down with a patient and talking to them about their specific set of circumstances around their disease. So we can do things like what we've talked about here to try and meet targets and provide patients with general information about prostate cancer or whatever other type of cancer we're talking about. But none of that replaces that individual assessment and consultation. So those are guidelines, and they're out there to help us set targets, but they are not prescriptive because there are circumstances. Pardon me?
It's not a treatment protocol.
No, there are algorithms in there that can help family physicians and patients who are looking at that to determine, okay, what's going to happen to me next, or what should be the next step in this process. But as I said, they're not prescriptive, and there are always circumstances where patients don't fit the algorithm, and so you have to respect that.
This question might actually lead into your next topic. I'm not sure here. Once you've gone through screening, in the last week or month or so, we've heard of some publications that have stated that there's 4 significant, and I'm not sure whether they're genes or some other smaller thing that they're looking at, that can be predictive of the seriousness of the disease. My question is not what's the status of that research as much as how is the Tom Baker and how is the Cross participating in trying to prove up the validity of those various indicators of seriousness of disease. And I'm using the word serious because I forget what the
I think what you're speaking to is, and I mentioned earlier that one of the challenges in dealing with this disease is that it's an extremely common problem. There are many men who live with it and die of something else, never being aware that they've had a problem with prostate cancer. We are looking for it harder, and so we're identifying it in more men. And we're treating men, many of whom may not need treatment. So we expose them to the risks and the complications of treatment without necessarily being able to say, we know that this is going to impact your risk of dying from prostate cancer. So the kinds of tests that you're talking about, though, that genetic profiling, we hope one day will get us to the point in time where we can use that information to look specifically in a patient's case and say, okay, because this gentleman has 2 of the 4 genes that we recognize are important in saying that this is a cancer that has the potential to behave in a bad way, that's a man who definitely needs treatment. If you're a man who doesn't have any of those genetic abnormalities, then depending on the circumstances, this may be a problem that we could just watch, or we could even leave alone, because it's never going to be a threat to your life. And so we're hoping that those kinds of tests will get us to the point in time where we can advise patients more specifically about what their specific risk is and whether treatment is something that they should undertake or whether it's something that they can afford to walk away from. We participate in that in the sense that a lot of those kinds of studies come out of what is called tissue banking. So when patients have their prostate gland removed, and this is done for many different types of cancer, not just prostate cancer, samples of that tissue, you sign a consent form, and samples of that tissue are sent to a repository where we store those samples, and 10 years down the road or 5 years down the road, a researcher could approach the repository and say, I have this specific question I want to ask about genes in prostate cancer, and I need to interrogate 1,000 prostate samples to look at this. And we have that tissue repository there in order to facilitate that kind of research and answer those kinds of questions. So we have tissue banking for all of the common types of cancer and are starting to develop it for some of the more uncommon types as well.
Well, at what stage the prostate cancer, if it is not treated, that will advance to the vertebral column or other part of the body?
That's a tough question to answer. Any man who's been diagnosed with prostate cancer is at risk for developing spread of disease to other parts of the body. The more advanced the prostate cancer is when it's identified in the prostate gland, the higher that risk. And the more aggressive the cancer looks when it's discovered, the higher that risk. So it's a difficult question for me to answer specifically, other than to say that any man who's been diagnosed with prostate cancer faces that risk. That risk may be very, very small for a man who has a low-grade, low-volume cancer that's been treated with curative intent. That risk may be as high as 50 to 60% for a man who's got a large cancer that has an aggressive appearance under the microscope.
So, doctor, there are different types of cancer also in the prostate cancer. Is there a fast-growing cancer and there's a slower cancer, like any other cancer? So in the prostate cancer, there's also there could be a very aggressive cancer?
Yeah, the most common type of prostate cancer is what we call an adenocarcinoma, and that's 80-90% of prostate cancers are adenocarcinomas, and then there are about 10%, there's about 10 other types that make up that other 10% that are extremely rare and unusual that we don't see very often. But that 90% of adenocarcinomas spans the gambit from cancers that have a very low potential to spread and cause problems to cancers which have a potential to behave very aggressively and in a nasty fashion. And we can look at things under the microscope that give us a clue as to where on that spectrum that cancer might sit, but it's not a foolproof science. I've got men in my practice who you know, by every piece of information that's available to us, they should have done very well with their prostate cancer with its localized treatment, and the chances of it coming back and causing them a problem was extremely small, and yet here they are coming to see me with metastatic disease. At the other end of the spectrum are patients who had a nasty looking cancer when it was first discovered, and my educated guess when I first met them 10 years ago was that they probably wouldn't be alive 10 years later because of how nasty this disease looked. And yet here they are still coming back to see me 10 years later and no evidence that their cancer's come back. So it's not an easy thing to predict.
That's intriguing. Are you suggesting that within one Gleason score that there might be an observation that says, how is that communicated to people?
With difficulty. Yeah,
is it just intuitive at this point? It's not.
No, I mean when you look at these things under the microscope, how closely do the cells approximate the normal appearance of the prostate gland? Is there are a lot of these cells dividing? So does it look like it's rapidly, the cells are rapidly dividing and potential to spread? Is there a lot of what we call nuclear atypia? So the nucleus inside these cells has a really abnormal appearance in comparison to normal prostate cells or a low-grade prostate cancer. So there are features that we can look at that give us some clue as to how this might behave, but it doesn't. The cancers don't read the books, and so it doesn't always correlate with the way it behaves in that individual
Within
patient.
one Gleason score number, there's this range.
There can be that range. That's right. Any other questions?
What else?
Okay. You've been waiting, I can see that. So a little bit of background just to set the context for some of these new developments. And a lot of this is probably information that you're already familiar with, but just so we're all on the same page. Prostate cancer is a disease that is fed by male hormone. So the testosterone that circulates in men and women also make testosterone, not as much, but prostate cancer cells are driven by testosterone. And that recognition, that goes back 50 years. The importance of testosterone and its stimulating effect on prostate cancer was recognized decades ago. And for advanced prostate cancer, the initial treatment of that, so if a man has disease that is spread to other parts of the body, we treat that by depriving the cancer of the stimulating effect of male hormone. And that years ago was done by removing the testicles. The testicles are the major source of male hormone in the body. And as I said, that observation that goes back 50, 60 years came from the fact that surgeons learned by observation that if you removed the testicles on a man who had advanced prostate cancer, in many of those men, the activity of the cancer would shut down. And that might control the disease for months, sometimes even years. Over the last 50 years, we've developed medications that we can use to produce that same effect. So we can block the production and the stimulating effect of male hormone by treating with drugs, and it has the same effect as the surgical removal of the testicles. And we call that androgen deprivation therapy. Until very recently, it was believed that if you have to go on androgen deprivation therapy for your prostate cancer, that is a treatment that needs to be done on a continuous basis. For anyone who's had the misfortune of being exposed to androgen deprivation therapy, you know the side effects and the risks and the complications that go along with that. So men whose bodies have been deprived of testosterone complain of fatigue. They don't have the same level of energy and vigor that they were used to having prior to that. It certainly has a profound effect on libido and sexual function. Some of the medications that we use to block the stimulating effect of male hormone can cause breast tenderness and enlargement, can have effects on a person's emotional health, cause problems with depression, and those are and cause hot flashes. So those are side effects that men on androgen deprivation therapy deal with on a day-to-day basis, and they can be they can make a huge impact on a patient's quality of life. Several years ago, this trial was started, was conducted through the National Cancer Institute of Canada. It was called the PR7 trial, and that trial was designed to ask the question, can we use intermittent androgen deprivation therapy as opposed to continuous therapy? So the advantage of that would be, hopefully, that men would get a break from the treatment and the side effects of the treatment, but not lose the advantages in terms of controlling the cancer. And so 1,500 patients participated in a clinical trial and were randomized to either continuous or intermittent androgen deprivation therapy. And the results of that trial were published last year, And what that showed us was that intermittent hormone therapy resulted in equally effective cancer control, as long as it's done under the right circumstances and patients are monitored appropriately, and that intermittent therapy was associated with a better quality of life for patients because they got a break from the treatment and from the side effects of the treatment. And it's even been suggested that intermittent therapy may be superior to continuous therapy because of other health impacts that androgen deprivation therapy can have. We know that a man whose body is deprived of androgen has a significant risk of developing problems with osteoporosis. Androgens are important for bone health. Men who have been deprived of androgen have a higher risk of cardiovascular problems. And so intermittent hormone therapy may help to obviate some of those other health risks. And so now, in the right set of circumstances, intermittent hormone therapy, I think, is a viable option for many patients who are being treated with androgen deprivation therapy. But it does need to be done under circumstances where patients are, monitored appropriately so that when it's necessary, the androgen deprivation therapy can be reintroduced. So that, to me, is a significant step forward for patients dealing with the side effects of this treatment.
What is the treatment starting point when a reoccurrence, of course, after radiation?
Or after surgery? Or
after surgery,
yeah.
At what point of the PSA level do you restart hormone therapy? Is it 6, is it 10, 12, 15? There's no
uniformly agreed upon number.
That's interesting.
Yeah.
How do you figure that out and when to start?
You have that conversation with the patient. That's why it needs to be individualized. Some men are very anxious about any rise in their PSA and want that problem treated, and so they would go on androgen deprivation therapy if their PSA even rises above 1 or 2. Other patients, once they understand what androgen deprivation therapy can and can't do, if they're feeling well, and the only problem we're dealing with is that their PSA test is elevated, but they're not sick from it, they might say, you know what, I don't want to go on that just yet. I'll look at that down the road if the prostate cancer is causing me more trouble. Or some people say, well, I'll set a target. Maybe if my PSA hits 20 or 50, that'll be the magic number for me. But there is no universally agreed upon number for introduction of androgen deprivation therapy.
Is that a comment before radical prostatectomy?
No, this is, so for a man who has had treatment for his prostate cancer with curative intent, okay, if there is concern that that disease has relapsed, and that's usually nowadays a concern because the PSA has taken a jump, the first question that needs to be asked is, are we dealing with a local reoccurrence of prostate cancer? So a reoccurrence down in the pelvis where the prostate used to sit before it was removed surgically, or where the vestiges of the prostate remain if you've had one of the other treatments. And if that's the concern, then there are other local therapies that can be done to try and deal with that problem. If the concern is more likely that the cancer has spread elsewhere, then that is not a problem that we can cure with any of these treatments. We can often control that disease for long periods of time, but the complications and the risks of treatment come with that. And so under those circumstances, men need to understand what therapy can and can't do for them. I can't cure your cancer with this treatment, so we have to strike a balance between the benefits of the treatment in terms of controlling the cancer and the price you pay, the side effects that come with the treatment, and the other risks to your health that that treatment might introduce if you're on that treatment for a long period of time. And men can be on androgen deprivation therapy for years. So it is a significant issue, those other health concerns that can come up. So that's the way I would approach that problem, is if the PSA goes up after a curative treatment for prostate cancer, you first have to ask the question, is this a local recurrence or more likely to be a recurrence elsewhere?
So you want to see an indication of the rise in the PSA first?
Well, an indication, what's the rise? And then we look back at the original pathology and say, is this a set of circumstances where we think there's a high risk of local recurrence? Or is this a set of circumstances where it's much more likely that the recurrence, this is something coming back elsewhere? And that will help to determine what direction the patient will go.
That's helpful. We've had quite a dialogue within our warrior group on that very specific question.
Yeah. And sometimes we don't know. Sometimes there are circumstances where we say, you know what, it could be a local recurrence, it could be elsewhere. And then again, you have to have that conversation. Well, if there's a chance that it's a local recurrence, do we want to look at, if you had a prostatectomy, do we want to look at radiation therapy to the pelvis where the prostate used to sit? And if it's a local recurrence, that can deal with that problem, but you add radiation therapy and the effects of that to a man who's already had surgery in that area, you're going to cause more problems with sexual function, with continence, effects of the radiation on the rectum, and the effects on bowel function. So it's an ongoing discussion. It's not something you can decide in just 1 or 2 visits. Okay. So advanced prostate cancer. And I'm going to talk about 4 things here. So manipulating the hormone environment further, a new chemotherapy treatment for men with advanced prostate cancer. You've all heard about, I'm sure, about Provenge, what we call a vaccine therapy. It's not really a vaccine, but we'll talk a little bit about that. And then I do want to come back to this issue of managing bone health, because that's very important. So manipulating the hormone environment, we've talked about the fact that the first step in the treatment of advanced prostate cancer is blocking that stimulating effect of male hormone, whether that's by a surgical procedure or by introducing these medications. The testicles are the major source of male hormone, but male hormone is produced in other tissues in the body as well. And although blocking male hormone production is effective in more than 85% of patients with advanced prostate cancer, it is not a curative treatment. And eventually, if you live with prostate cancer for long enough, those treatments fail. Eventually, the cancer develops resistance to manipulating the male hormone environment. We know that if we start to see signs of that hormone resistance developing, there are some medications available to us at the present time. You may recognize biclutamide and flutamide, also called Casodex. By adding those agents in, they're pills that are taken by mouth, 20 to 25% of the time we will see a fall in the PSA again, suggesting that that further manipulation of that residual amount of testosterone by adding in these agents will have some effect on the cancer, but unfortunately those responses are often short-lived. A few months, a year, maybe 2 years, then the disease starts to develop resistance to that again. And the obvious question that researchers have dealt with over the last 10, 20 years is, can we do something to improve on these kinds of results? And the answer to that question is finally yes. So there's a new agent called abiraterone. Doesn't have a trade name yet. This is a really a fascinating drug, and I think going to have a huge impact on the treatment of prostate cancer. So it's an inhibitor of an enzyme called CYP17. CYP17 is one of a series of enzymes that are important for converting other hormones to testosterone in other tissues in the body. So I mentioned earlier that the testes are the major source of male hormone. They produce over 90%, but a little less than 10% of male hormone is produced in muscle and liver and other tissues in the body that is converted by this and other enzymes to testosterone. And what this drug does is blocks that enzyme. It's a drug that is taken by mouth. It's given in combination with a drug called prednisone, and it is extremely well tolerated. It can cause a bit of fluid retention. It can cause a low potassium. Some men complain when they're on this of fatigue. occasionally causes some headaches and increases in blood pressure. These are all issues that we can deal with quite easily and quite effectively. And abiraterone has been tested in 2 important clinical trials. They're called the Cougar studies. So the first study was a study involving 1,200 patients, and that was conducted worldwide. So this was men whose disease was advanced to the point where they were no longer responding to hormone treatment, and they'd gone on to receive chemotherapy treatment for their cancer, and the chemotherapy was also no longer working. So these were men who had very advanced disease, didn't have a lot of other options available to them to manage their disease, and so they participated in this trial. And the really gratifying thing to see was that 85% of men who were randomized to the active treatment arm with the new drug had a response to the drug. PSAs fell, and that response was associated with an improvement in survival. It was a small improvement, a matter of several months, but when you consider the fact that this was a trial being conducted in patients with very advanced disease that was resistant to many of the treatments that we use to treat this, that's a significant impact. And in cancer research, in testing new drugs, the gold star, the gold standard, is being able to demonstrate an impact in overall survival. And we aren't able to do that very often with new cancer treatments. Often what we see is an improvement in what we call progression-free survival, which means that the cancer doesn't come back as soon, but we can't actually demonstrate yet that that actually means that people live longer or better with their disease. That's overall survival. And with this drug in that study, we saw an impact in overall survival. Apologize again. So there is another study with the same drug. Now this is being done in patients earlier in the course of the disease. So these are patients who are developing resistance to hormone treatment but haven't yet received chemotherapy. That study has accrued over 1,000 patients. We participated in both of these trials here in Calgary, and we don't have the results on that study as yet. We'll probably see those results over the next year to 18 months. But I am quite optimistic that we're going to see similar benefits in this set of patients. And so I think this drug is going to have a significant role to play in managing disease that is becoming hormone resistant. The drug is now available through a special access program in Canada. It's going through all of the appropriate regulatory approval, which is a lengthy process in Canada. But Health Canada, recognizing this impact on overall survival, has established this special access program. So for a patient who has progressed through hormone treatment and chemotherapy, we now have the potential to access this agent through a special access program. And I have several patients on it under those circumstances, and we are seeing some very gratifying responses. And the really nice thing is that the treatment is extremely well tolerated. Patients don't complain of a lot of side effects with this treatment, so huge advantage that way. So and as you see the benefit in advanced disease and then move it earlier and earlier in the course of the disease, once you see an advantage in the metastatic setting, the next obvious question is, what if we use the drug in earlier stages of prostate cancer? Is that going to improve survival and outcomes? And so this drug will be going through a series of clinical trials over the next several years, assessing it in earlier forms of prostate cancer. Another agent called MDV-3100, another drug that I'm very excited about. So this acts by a slightly different mechanism. It actually, on cells in the body that are sensitive to male hormone, they bear on their surface a protein, a receptor that the male hormone binds to, and it stimulates the effects that it has in that cell. What this drug does is occupy that receptor and prevent male hormone from sitting on that receptor and stimulating whatever activities male hormone causes in those cells. So this is an androgen receptor antagonist or blocker that is also undergoing clinical trials. The other thing that this drug seems to do is promote what's called apoptosis, or what we call programmed cell death. So all cells have a life cycle, and built into their genetic makeup is a process that assures that once that cell has reached the end of its life, it dies appropriately. Many times in cancer, those mechanisms are aberrant, and programmed cell death doesn't occur, and so the cells keep growing and keep dividing, and they can do that for years. This drug seems to reinstitute that normal mechanism of programmed cell death in cancer cells. Again, it is an orally administered agent, often very well tolerated. The major complaint from patients who will go on this drug is fatigue. And there are 2 pivotal trials, again, conducted worldwide, ones that we have participated here in Calgary and in Edmonton. The first is called the AFFIRM trial. So 1,200 men have been randomized on that trial. These are men, again, with very advanced disease that has stopped responding to hormone treatments and to chemotherapy. And that trial completed its accrual of patients in November of 2010. So we expect to see the results from that trial over the next year to 2-3 years. The second trial is called the PREVAIL trial. So again, because of the anticipated results here, we're looking at using the drug in patients who are developing hormone resistance but haven't progressed to chemotherapy yet. And that trial is presently accruing patients. We have that trial active here at the Cancer Clinic. So I think both of these drugs are going to have a significant impact on the way we manage advanced prostate cancer, and potentially, down the road, earlier forms of prostate cancer. And disease that we once called hormone refractory or hormone resistant, we are learning with better drugs, more effective drugs, we can manipulate that hormone environment effectively, and what was once considered hormone resistant is no longer. I think one of the big advantages here is that these agents will delay the need to introduce chemotherapy treatments. Chemotherapy for prostate cancer, for any type of cancer, is difficult treatment. A lot of side effects associated with that. Not all men with advanced prostate cancer are eligible for chemotherapy treatments if they have other problems with their health that would make getting through that kind of treatment very challenging, or where there's a significant risk of toxicity and side effects from chemotherapy that might actually put that patient's life in jeopardy. We can't always use that tool. So not all men with advanced prostate cancer can receive chemotherapy treatments. These drugs are extremely well tolerated, and I think are going to push back the need for chemotherapy treatment, and will be something that we can look at using in a much larger group of patients, even patients who have other challenges with their health that might make introducing chemotherapy a difficult thing to do, or not in that patient's best interest. So those are 2 new agents that I think are really going to change the landscape over the next few years. I've talked a little bit about chemotherapy treatment, and there is a new drug I want to tell you a little bit about. For men, at the present time, for men who have developed resistance to hormone treatment, we look at treatment with a chemotherapy agent called Taxotere. And that's given by an intravenous injection. It's given once every 3 weeks. Causes a lot of the side effects that people think about when they hear about chemotherapy treatment. So fatigue, nausea, hair loss, risk of infection. It's tough treatment to get through. But we learned from clinical trials that were conducted in the early 2000s and published in 2006 and 2007 that under the right circumstances, this treatment for men with advanced prostate cancer helps to improve survival, buys them time, and it helps in disease and symptom control. If a man has had treatment with Taxotere and then his disease starts to progress, while there is another chemotherapy treatment that we can use in those circumstances, we've never been able to demonstrate that that treatment actually improved survival. So treatment with a drug called mitoxantrone, which is an old chemotherapy drug, has palliative benefits in that set of circumstances. About 20% of men who go on that kind of treatment derive some benefit from it in the sense of it helping to manage the symptoms their cancer is causing for them. But not a huge number. That means I have to treat 5 patients and introduce the side effects and the toxicities of treatment potentially to see 1 patient benefit. And as I said, although there are palliative benefits associated with this treatment, it hasn't been shown that that impacts survival. But we have a new agent called cabazitaxel. It's a 3rd generation taxane, so a newer relative on a kid on the block of Taxotere. Taxotere is what we call in the class of drugs called taxanes. So cabazitaxel is a new form of taxane, and in a study with 755 men with advanced prostate cancer whose disease was no longer responding to Taxotere, treatment was compared cabazitaxel to mitoxantrone, and those results were published last year and showed an improvement in survival, in disease control, and in symptom control. The challenge, I'm sorry, again that's cut off at the bottom, it's toxic treatment. This is a tough drug to administer and a tough drug for patients to get through, particularly when they've been through previous chemotherapy treatments. So it is, it has the advantage of creating another option for patients, but not all patients are going to be candidates for this kind of treatment because it is tough treatment to take. Any questions before I move on to...
With these drugs you're talking about, this is where the disease of cancer is confined still just to the prostate?
No, this is advanced disease. So this is disease that has spread to other parts of the body. There are clinical trials looking at Taxotere, the chemotherapy agent, in earlier forms of cancer. So if a man has what we call high-risk localized prostate cancer, so a cancer that has an aggressive appearance under the microscope, a high Gleason score, or has a large tumor, and we recognize that in spite of our best efforts to cure that with either surgery or the other localized treatments, there's a high risk that that man's cancer is going to come back. There are clinical trials looking at adding Taxotere to whatever treatment is being done to treat the local problem. So surgery combined with 6 cycles of chemotherapy with Taxotere, or radiation therapy combined with treatment with Taxotere, much as we do in breast cancer nowadays. If a woman has a breast cancer removed and there's a circumstance where there's a high risk of that disease recurring, she will receive a recommendation to have what we call adjuvant chemotherapy. So it's chemotherapy given with the intention of reducing the risk of the cancer coming back. And we're just at the point with prostate cancer treatment where we're now starting to entertain that same kind of treatment for prostate cancer. So not part of prime time use yet, but 5-10 years down the road, we may well be looking at using chemotherapy in a similar set of circumstances for high-risk localized disease.
Dr. Ruether, 2 of the men in our advanced prostate cancer group have participated in a trial of something called SB939. And one of them did very badly on it and had to stop. And another is doing extremely well on it. Could you comment on that drug?
I think it's another, it's kind of like cabazitaxel. I think it's an interesting drug. I think it will have a place. It's difficult to know yet where it's going to fit. And as you've indicated, it doesn't work for everybody. And like other forms of chemotherapy, it can be a very toxic treatment. So that's part of what we learn in doing clinical trials. Yeah, we can give the drug, and it may be helpful, but we have to balance that off against the problems we cause by giving these kinds of treatments.
Was that drug the Tubalon? Is that the main drug?
That's another one. Yeah. That's another one.
Do you think that the Alberta will fund abiraterone if you could get it through the early?
Eventually it will be funded. It would be very, very difficult for them not to fund an agent that has an overall survival benefit. But before it's Funding for treatments in our system in Canada, there's a bit of a disconnect that creates a problem for us. The approval to use an agent in Canada falls under a federal jurisdiction. So Health Protection Branch Canada has to review the data around a new treatment and decide yes or no, this is an appropriate treatment to make available in Canada. For cancer treatments, then that drug goes through a review by an organization called PCODR, the Pan-Canadian Oncology Drug Review, and that's a panel of experts from across the country who work in oncology, look specifically at cancer drugs, and look at the pros and cons of this new treatment. What are the benefits? What are the costs? And then PCODR makes a recommendation as to whether an agent should be approved for use or not. But then it is up to the provincial bodies to decide whether they're going to fund it. So Health Protection Branch can say, yeah, we want to have this in Canada, and PCODR can say this is a good drug and it should be available to Canadian patients. But then there's a disconnect. And so the wealthier provinces, Alberta, BC, tend to bring drugs on sooner than provinces that have more challenges in terms of funding those kinds of agents. So there is a big discrepancy across the country in terms of when these agents become available. I think it would be, I can't see this agent not being funded once it's gone through that process because there is an overall survival improvement associated with it. But that's probably 18 months to 2 years down the road because of the processes that it has to go through.
The drug might be available earlier than that, but could the patient buy it and pay for it?
Well, there is this special access program. So in the right circumstances, we can apply to get the agent for the patient. And presently, while it's going through this review process, the company that makes the drug is supplying the drug without cost to the patient. Once the drug has had Health Protection Branch approval, generally what happens is those special access programs are closed down because now it is approved for use in Canada. So it's up for PCODR and the provincial jurisdictions to figure out where this fits and whether they're going to pay for it. So we do have the challenge of a disconnect of there can be a year to 18 months between when Health Protection Branch approves an agent and when it actually is funded and available to physicians to prescribe to patients. And so that when that time comes, we will have a challenge to deal with.
Dr. Ruether, one of the members of our group is in queue for this special access to abiraterone, but is having difficulty, getting this access. Would you offer any advice to him? What should he do? It's difficult for sure. There's a lot of, and it's not just difficult for the patient, it's difficult for the doctors. There's a lot of paperwork that needs to be completed to get these, to access these kinds of programs. And every time a special access program is set up, it's not the same as the last special access program. So they're all a little different. This drug, although it's manufactured in Canada, is provided through the special access program out of the United Kingdom. Don't ask me why. I don't understand how that works. But so there's a whole series of, we have to apply to Health Canada for an individual patient. Health Canada has to approve it. That approval has to go to the company that manufactures the drug and supplies it in the UK. And then after jumping through another series of hoops, the drug is shipped. Usually when these special access programs become available to us, there's almost always some glitches that need to be worked out with the first few patients getting onto them. And when this one opened up, not surprisingly, there's been a real flurry of activity. Health Canada had something like 80 applications within the first week when the special access program opened up. And I don't think they anticipated that kind of an onslaught, so they're a bit behind the 8 ball as well. All I would say to the patient is he needs to work with his doctor. The bugs will get worked out, and the drug will be made available to the patient as long as it's the right set of circumstances. But if he's in the queue for the special access program, I assume that he's met those requirements and the application is in. Yeah.
That's intriguing. I'm thinking there's a reason for a greater level of advocacy by yourselves as physicians and oncologists and support group like ourselves.
Yeah.
My question really was centered around when a premier agency like US FDA or an agency out of, a comparable agency out of Europe is the central agency or the key coordinating agency to bring a drug through its phase 1, 2, and 3. And our Canadian institutions get involved perhaps in increasing levels up to a phase 3. Why should it take another 2 years for our federal agency to review data that's gone through a very high level of analysis with Canadian participation, and then another year or two for provincial authorities to come in? What's the block there? Because I don't understand.
I think there's several. My first comment would be a word of caution in the sense that just because the US FDA approves something doesn't mean that we should automatically jump on the bandwagon, because the practice of medicine in the US is a bit different than it is in Canada. It's a business, and I say that with a little bit of hesitation, but we have seen circumstances in cancer care where the US FDA has approved agents with little evidence of benefit or questionable benefit, and they've been pushed to bring something on board because of advocacy, and these agents cost millions of dollars, and then 2-3 years down the road, the benefits that were touted in clinical trials that resulted in the agent being brought on board don't translate into benefits out in everyday practice, and the FDA is going back and removing or pulling off an indication for a treatment. The best example of that is a drug called bevacizumab that's used mostly in colorectal cancer, but it is used in other cancers. That agent was approved for use in breast cancer a couple of years ago on very little evidence. It has cost the US system millions of dollars, and they're now revisiting that decision because it's questionable whether it does in fact result in improved outcomes. So the delays aside, and while I am frustrated by those delays as well, I think we can be very proud in Canada of the way our health agency, the level of scrutiny that our health agency puts to these kinds of agents. It's also important to remember that we learn a lot about what these drugs do in clinical trials, but we also learn more about them as they're introduced in everyday practice. So there's what we call phase 4 testing, which you don't hear a lot about, but that is mechanisms that are put in place to track what happens with these agents when they get out into general use in the public. And a good example of the impact of phase 4 testing, a few years ago there were a couple of non-steroidal anti-inflammatories that were pulled off the market because of concerns about higher risk of cardiovascular complications. Those were not things that were seen in phase 1, 2, and 3 trials, and it was only when the agent became used in a much broader sense and we were tracking that data to say, wait a minute, there's a problem here. And so it's frustrating and it's slow, but it is done with the intention of trying to introduce these agents in a way that is as safe as we can make it, and that we're not missing the opportunity to learn about other impacts of these drugs as they become used on a wider basis. So the disconnect between the federal authorization and provincial funding is a problem throughout healthcare. It's a feature of the way healthcare works in Canada. PCODER, that Pan-Canadian Oncology Drug Review process, is an attempt to try and deal with that issue. That's a relatively new body, just set up over the last couple of years. And the intention is to create a national body that has the expertise to look at cancer therapy. And it is our hope that we can set up processes such that if a drug has a P code or review that is positive, that's going to lead to accelerated availability through provincial formularies. There's a lot of work to be done in terms of making that work, and it still comes down to somebody's got to pay for it. And introducing a drug like abiraterone, even in the province of Alberta, we'll be talking about an agent that will have an impact of several $1 million for the province. So, you know, and the problem with medicine is the sense that we are always going to develop better technology, better treatments. So it's a never-ending sinkhole. There's always going to be something else that comes along that's a little better, but it's more expensive. And how do you figure out in a publicly funded system what we pay for and what we don't? So it's a real challenge.
Debate for the upcoming election.
Oh yeah. So I'm just going to talk a little bit about what we call vaccine therapies, although it's not really a vaccine. You've probably all heard of something called Provenge. Its other name is Sapulacel T. A vaccine, when we talk about vaccines, what we're talking about is a form of treatment that prevents a disease. So you can be vaccinated against smallpox, you can be vaccinated against polio. So you're given something that prevents you from ever developing that problem. It's a little different here in that this is a treatment that is being used in men who have prostate cancer. It's not a vaccine in the sense that it will prevent prostate cancer, but it's called a vaccine therapy. So what this involves is extracting from an individual patient what are called dendritic cells. So those are cells that are one portion of the cellular component of a patient's immune system. And then those cells are modified so that they recognize a protein called prostatic acid phosphatase. And prostatic acid phosphatase, or those cells are then infused back into the patient after they've been modified. Prostatic acid phosphatase is a protein that sits on the surface of 95% of prostate cancer cells. So what this therapy does is it tricks the patient's immune system into recognizing prostatic acid phosphatase as a foreign material, and it sets up an immune response. And this has been studied in over 500 patients. This was done in patients who had cancer that had spread to other parts of the body, but they had no or only very minimal symptoms from their disease. So they were very well, and that's important because this is not a small treatment to undertake. It involves extracting the cells from the patient's blood, very much like going through a dialysis procedure. So the blood has to come out and be filtered through a machine. You have to be well enough to go through that procedure. It's a very labor-intensive and costly treatment. A treatment for an individual patient costs about $93,000 US. But the studies have shown a small improvement in overall survival with this technology. And the struggle now is to figure out where this fits in the context of these other treatments we've talked about, and if we were going to introduce this kind of treatment in Canada, where it would fit in terms of funding, because we're not actually talking about a drug treatment. So our drug programs would say, well, this isn't for us to look after because it's not a drug. It's not a surgical treatment. It's not radiation. So we kind of have to create a new place for this, and then there will be the debate about, well, how do we pay for it? I think the exciting thing about this is that the potential to use this kind of technology to stimulate a patient's immune system to respond to their cancer is something that it's been kind of a holy grail in cancer treatment for decades. And previous attempts to do this have not been successful. So vaccine therapy for cancer although it's been tried in experimental forms over decades, has been very disappointing. This is one of the first set of circumstances where we've actually seen the potential for this to be beneficial. And so it may be something that is of benefit to patients with prostate cancer. The technology has the potential to be applied to other types of cancer as well, which opens up another great big kettle of fish in terms of where does it fit and how do we pay for it. But it's exciting nonetheless. So the last thing I want to talk about, and this is not specifically related to treatment for prostate cancer, but is a very important issue for men with prostate cancer, and that's issues related to bone health. When prostate cancer spreads to other parts of the body, one of the most common places that it affects is the bones. And we know that thinning of the bones, osteoporosis, which is a very common problem for all of us as we age. We hear a lot about it in relation to women's health, and it is a much more common problem for women, but it is a very common problem for men with prostate cancer. 30 to 40% of men at the time of diagnosis of prostate cancer, if they have a bone density assessment done, already show some thinning of their bones, what we call osteopenia, the earliest stages of osteoporosis, or frank osteoporosis. So it's a very common problem in men with prostate cancer, and it's very important for men with prostate cancer to be aware of what they can do to look after their bones. And the things that you can do are making sure you're getting enough calcium and vitamin D in your diet. Most of us as adults are not big dairy consumers, so we probably don't get enough calcium in our diet. And living in this part of the world and not being exposed to the sun, we don't make very much vitamin D. If I measured vitamin D levels on everybody in the room here, if you weren't taking vitamin D supplements, probably 85% of us have a subtherapeutic level of vitamin D living in this part of the world. So it would be a very safe thing for a man with a diagnosis of prostate cancer to put themselves on some calcium and vitamin D supplementation. The other thing you can do to look after your bones, quit smoking because it increases your risk of osteoporosis, and weight-bearing exercise is a good way to preserve bone health. But the other thing that is exciting is that over the last several years, this is not so recent, over the last decade, the introduction of drugs called bisphosphonates. And so there's some names there that you may recognize: Didrical, Fosamax, Zometa. These are agents which can be used to help a patient maintain and potentially even gain back some of the bone density that has been lost associated with aging and time. And so again, something that I think is very important for patients with prostate cancer to be aware of. Talk to your family doctor about bone health. Very reasonable thing to have a bone density assessment done. And if the type of lifestyle interventions that I've mentioned with calcium, vitamin D, quitting smoking, exercise, don't have the desired effect, these medications can be prescribed to help manage problems with bone health. And there is a new agent on the market called denosumab, which acts by a different mechanism than the bisphosphonates, that also can help to preserve bone density. And the advantage of this agent is that it can be given by a very quick subcutaneous injection twice a year and help with bone density issues, and a very well-tolerated drug. There is even some suggestion that in patients who have cancer that is affecting their bones, breast cancer commonly does that, prostate cancer is the other common one, but other types of cancer as well, kidney cancer, that these agents may actually have some impact on the way the cancer behaves in the bones, as well as dealing with concerns related to osteoporosis. So this is an agent that is going through clinical trials right now in those arenas, in osteoporosis and in the management of metastatic cancer that is affecting the bones. So I hope I've showed you tonight that there are a lot of things have changed over the last couple of years within Alberta in terms of the resources that are available to patients and the treatment programs that are available to patients with prostate cancer, and on a larger scale, a lot of very exciting developments in the management of this disease, both from the point of view of managing localized prostate cancer, but also in managing advanced disease, and things that are effective in managing advanced cancer will almost certainly down the road have a role to play in managing earlier forms of cancer and hopefully improve the outcomes for patients who are diagnosed with potentially curable disease. So prostate cancer is becoming a bit like breast cancer. I used to say that breast cancer was challenging to deal with because I had too many options. There's lots of different hormonal treatments, lots of different chemotherapy that can be used. And I wish prostate cancer was like breast cancer because we didn't have a lot of choices. In fact, it's becoming more like breast cancer all the time in that we have an expanding number of options available to us that are going to help us to manage this and turn this into a chronic illness, which is what we're doing slowly with most types of cancer. And those changes are in early diagnosis and screening, improved outcomes for patients with all stages of disease, and an expanding number of therapeutic options for both localized and metastatic disease. Thank you.
Dean, you've been...
Sorry, at the back?
I read that drug Avodart can reduce your PSA by 50 to 70%. When would it be prescribed?
So it's yes, it can have an impact on PSA. The question is, does it have an impact on prostate cancer? And that's the question we don't have an answer for. So it is not an agent that we use in the management of prostate cancer. Many patients with prostate cancer can end up on Avodart, though, because they can also have problems related to benign enlargement of the prostate that can cause urinary difficulties, and Avodart can be helpful in managing those. And sometimes it produces a fall in the PSA. But does Avodart actually have a role to play in managing prostate cancer? We don't know for sure.
And Avodart is similar to Flomax?
Yes. Yeah, and again, Flomax, the same thing. Can cause a fall in the PSA. It can be helpful in managing symptoms related to benign enlargement of the prostate. Does it help in managing prostate cancer? We don't know. But many patients with prostate cancer are on it, and it can affect their PSA.
Yeah, you mentioned, Dean, about chemotherapy and surgery.
Mm-hmm.
But you never said anything about radiation. Does that fall into this at all?
It does. For a man with early stage prostate cancer, in Alberta, there are 4 options for localized treatment. So there's surgery. There's what we call external beam radiation treatment, which is radiation given from the outside over a course of several weeks. There's what we call brachytherapy, where radioactive seeds are implanted into the prostate. And then there's something called cryotherapy, which is freezing of the gland. And those treatments, in patients appropriately directed to those options, the cancer outcomes are equal. The potential for those treatments to control the disease are equal. Radiation therapy also has a role to play if a man has had his prostate gland removed, and if there's a concern at some point afterwards that the cancer may have recurred in the pelvis. That's something that might be treated with radiation. And then radiation can be very effective in managing disease that is affecting the bones. So if there's a site in bone that's causing pain, radiation can be very effective in managing that problem. Although it doesn't cure the cancer in the bones, it can be very helpful in managing the pain. So radiation therapy is a very important tool in managing all stages of prostate cancer.
I've got a question for you, and I'll set you up in the coming environment that we've got politically in the next 12 months, and you can back if you wish, but you're managing the provincial GU.
Yeah, I'd put that in quotations for sure. Yeah. I skipped the meeting, so I got stuck with the job. Yeah.
What would be the next thing that you'd be advocating for?
I think the biggest question that we have to address as a group is access to PSA testing and whether we need to be looking at a screening program for the province. And then, so just sort of in order, I think those are the things that are top priority. And then lower down on the list would be the fact that, you know, geographically, patients are really spread out throughout the province. The two tertiary care centers, Calgary and Edmonton, where patients have access to things like robotic surgery, radiation treatment, brachytherapy. You have to come to the tertiary care centers for that, and that creates a challenge for patients who live remotely from those two centers. And so I don't think they have quite the same level of access. That's not an easy thing to fix, but I think there are things we can do as a group to try and make those options available for patients who don't live in the tertiary care centers or close to the tertiary care centers. And I really believe that if you are a patient in Alberta, you should have access to, whether you live in Grand Prairie or, you know, Beaver's Kneecap, you should have the same access as a patient who lives in Calgary or Edmonton. And so those are, I think, are the three biggest things that we need to address.
I've been on abiraterone now over 2 years, and I'm happy to say, like you said, very, very few side effects, other than weight gain and fatigue are the ones that have bothered me. But not to the extent that ever stopped me from doing anything I wanted to do.
Mm-hmm.
So 28, actually later this month it will amount to 28 months that I have been on this drug. So in my case it's been extremely successful. I just thought I'd pass that on.
Yeah, so you must be on one of the trials then?
Yeah, I was in the initial trial.
Yeah.
At that time, when before I began the trial, my PSA doubling time was down to 6 weeks. And so it came along at a very opportune time.
Yeah. I have patients on the trials who have had incredible responses to these agents, PSAs of 400 and 500 that have come down to undetectable levels or less than 10, and their disease in their bones is under good control. They're active, engaged in their normal activities. So there are side effects, as you've spoken to, but I'm really encouraged by what I see with these agents. And as I said, I think they're really going to change the landscape in terms of how we manage this disease, and in ways that will be so much better tolerated for many patients who can't necessarily look at the more aggressive and harder to receive treatments. I would be very happy to be giving a lot less chemotherapy for prostate cancer if we could manage it with these kinds of agents.
I'm one of your patients.
I know.
And, I too have had amazing success with that. Thank you.
Well, thank you very much, Dr. Ruether.
My pleasure.
We really appreciate your time coming out this evening, and based on the quantity of questions, I would say that you've answered a lot of questions that have been lingering, and
I hope so.
We really appreciate your time. Before you go, just a small,
thank you.
Very small token of our
Thank you very much.